Hope you're all doing well. Welcome back to my channel. So today we're going to be breaking down a critical tool that I've used in the GI and ICU, and it's known as the Forrest classification, and it's a tool in deciding the best management for upper GI bleeds. This is an endoscopic grading system, so it helps with stratifying rebleeding risk in patients with bleeding peptic ulcers and also guides decisions during the EGD. So let's go top to bottom. As you can see here, 1A is a spurting arterial bleed. This is the most dramatic. You're looking at active pulsatile spurting, typically from an exposed artery. The rebleeding risk is 60 to 100%. And this is a medical emergency. You must perform endoscopic therapy immediately, usually combining both epinephrine injection, thermocoagulation, or hemoclips. Patients like these often need ICU level care, serial hemoglobin checks, and close hemodynamic monitoring. Moving down to Forrest 1B, that's an oozing bleed. So instead of spurting, you see slow oozing from the ulcer base. This is still considered active bleeding, it's just less forceful. Bleed bleeding risk is around 50%. We treat this similarly to 1A with combination endoscopic therapy and sometimes repeat scope, depending on clinical status. You should also note proton pump inhibitors, PPIs, should be IV high dose continuous or bolus infusion. Typically, you'll do this around 80 milligrams bolus, followed by an 8 milligram per hour drip. Moving down to 2A, this is non-bleeding visible vessel. So this is essentially high risk stigmata without active bleeding. In 2A, there's a visible vessel in the ulcer base, but there's no active bleeding. The idea here is that it's poised to erupt, or it could very easily start bleeding. So they say the rebleeding risk is around 40 to 50%. You still need to treat this aggressively with EGD, usually with hemoclips or thermocoagulation, because basically the vessel can rupture at any time. What 2B is an adherent clot. 2B is when you find a clot firmly attached to the ulcer base, often covering a visible vessel. Rebleeding risk drops to 20 to 30%, but there is controversy here is whether to remove the clot. Many guidelines recommend vigorous irrigation to dislodge the clot, then treat any visible vessel underneath. If it won't come off, some will treat empirically, others leave it and start PPI therapy. 2C is a flat pigmented spot. Now in the lower risk of territory, flat pigmented spot, usually dark or hematine stained without active bleeding. Rebleeding risk is much lower, around 7 to 10%. Endoscopic therapy isn't always needed here, but aggressive PPI therapy is crucial. If the patient is stable, you can usually manage medically unless other risk factors exist, like anticoagulation or prior bleeds. Forrest 3 is a clean ulcer base with no clot, vessel, or bleeding. This is the lowest rebleeding risk, only 3 to 5%. In most cases, no EGD is needed. These patients can often be discharged early on high dose oral PPI. This is a key distinction in deciding who needs urgent EDB versus conservative therapy. So how do we use this classification? 1A and 1B need immediate intervention and close follow-up. 2A and 2B are high risk even without active bleeding. These are still often treated with EGD. 2C and 3 are typically treated with PPI and close outpatient monitoring. The system not only predicts rebleeding, but guides when to repeat EGD, discharge, or escalate care. Always consider the full picture: hemodynamics, hemoglobin trends, anticoagulation, and comorbidities. So, a quick recap: a spurting bleed has 60 to 100%, oozing is 50, visible is about 40 to 50, a clot 20 to 30, flat spot 7 to 10, and a clean base is 3 to 5. Remember, course 1 and 2A and B are high risk. Treat endoscopically. 2C and 3 are low risk. Treat with PPI and observation. If you're studying for step 3 or rounding as a fellow, mastering the Forrest classification will help you triage bleeds more confidently, coordinate with GI, and anticipate who needs close monitoring. Don't forget to like, comment, and subscribe for more high yield GI and ICU content. See you next time.